Hello everyone, this is the substance-related disorders PowerPoint lecture for chapter 22. Now, as your chapter discusses, we're going to be looking at substance use disorders, which includes the addiction and abuse, and then substance-induced disorders. So the DSM-4 has classified all of these. And first of all, with substance abuse, I want you to know the definition that's there. And the big thing to know here is that all A through D, all of those are situations that have consequences for the individual when they have substance abuse. They have a failure to fulfill major role obligations, continue to use even though they have physical hazardous situations, which might be, blackouts where they're falling down, injuries, maybe they're getting in physical altercations with others, recurrent substance-related legal problems, as I mentioned before, maybe DUIs, disorderly conduct, and then the last one, consistent substance despite, issues in their relationships, social obligations. And then the DSM-5 has also added cravings to that as well. The next, substance addiction. Again, to know that definition, but we know now with this, physical addiction is physical dependence on the substance, and that's evidenced by cognitive, behavioral, physiological signs and symptoms, which the individual continues to use despite problems. And there's also tolerance here in substance addiction, which is, you guys know this, needing increasing amounts of the substance to achieve the desired effects. And withdrawal signs and symptoms, and those are associated with lowered blood or tissue concentration after the individual is a heavy user. Now, in addition to the substance addiction, just note that they're going to have all of the same things as substance abuse, all that A through D that I mentioned, or A through E that I mentioned up in substance abuse, plus the tolerance and the withdrawal. Substance-induced disorders, substance intoxication. And again, this is a reversible syndrome, but there's physiological and behavioral changes due to that substance in the person's CNS, and it has a direct effect on that. Judgment becomes impaired. Social and occupational behaviors are also impaired. Substance withdrawal is, just as the definition says there, after the person is going to have changes that occur after reduce or stop the heavy and regular use of the substance. So predisposing factors and etiology. First of all, we have the biological or genetic theories that are out there, and genetic predisposing factors definitely appear to be involved. Children of alcoholics are 4 times more likely than other children to develop alcoholism. There's also many twin studies out there that do show a correlation or do show a genetic component. Biochemistry, we know that dopamine and GABA are neurotransmitters that are affected and play a role in substance abuse. The neuronal pathways, which are that sense pleasure and reward, those become activated and cause a pleasurable sensation when a person uses a substance, and this often creates a memory when that pleasure sensation, and it fires off the dopamine and GABA, and then that increases our desire to engage in that behavior or that substance abuse. So it's the brain reward circuits are involved there. I also have disease of the brain there, and many in the biological circles definitely believe, and not everybody necessarily ascribes to this theory, but that substance abuse is a primary disease, and they base that on is that substance abuse is a progressive illness. It starts slow but has different stages, and we'll look at those in a little bit. It's progressive and chronic. It continues to last for most of the person's life. However, you can be in remission. It can be fatal. A person can die from primary disease of substance abuse, and that it also is treatable. So many people will say that it is a primary disease of the brain. The fact now that we categorize it this way, most insurance companies will pay for, hospitalizations, for withdrawal, substance abuse rehab programs, and the like. Whereas if it wasn't necessarily diagnosed as, a primary disease, then we may not ever have insurance companies paying for it. Although some people do find this somewhat controversial, because if we say that it is a primary disease or it's a disease of the brain, that may give people a cop-out in not taking responsibility for their behaviors. But that's not what the disease of the brain is saying, that you don't have any responsibilities, but there are many people who don't like thinking of it as a primary disease. So just keep that in mind when you're talking to family members and looking at the literature. The second theory or psychological predisposing factors, self-medication. Psychologically, many people may be using substances for panic attacks, panic signs and symptoms. We see this often with people who are self-medicating for post-traumatic stress disorder, self-medication for anger, depression, that sort of thing. We also know psychologically that there are many personality traits that are correlated with substance abuse, not necessarily causing the substance abuse, but there's a correlation. And again, this doesn't mean that people who automatically, if you have these traits, that you're abusing substances, but there is that correlation. Decreased self-esteem, depression, passivity, and many other traits. We also know with some other psychological predisposing factors is people that have irrational thinking patterns. Sometimes people will call these addictive thinking, are very much correlated with substance abuse. The addictive thinking of denial, projection, rationalization, and we'll get into some examples of that later on in the lecture. But also we remember denial, projection, rationalization also as defense mechanisms. Sociocultural predisposing factors, first of all, social learning, and we know that as children we are very influenced by our family, how we are raised, the influence, many things we learn from our families by the way that they model, by the way they influence, our early childhood. How does our family model dealing with stress? How does our family model celebrating, special occasions? And if our family, is using substances, alcohol, and doing a lot of modeling through that, then that is social learning. So that's one predisposing factor. Another, under social learning, peers, whether it be in adolescents or in adults, that also has a very strong influence as being a predisposing factor. Conditioning. This is basically, repeated exposure to the stimulus, which causes a pleasurable experience, and then we continue to repeat it. So if we use substances and we have a pleasurable experience with that, then that is seen as a reward, and that encourages us to repeat the behavior. And every time we repeat it and have a pleasurable experience with that, it reinforces it. And then we are conditioned, in a sense, to start seeking out that same experience or seek out that substance. So it's not only the substance, but the environment too can also influence that reinforcement. So depending on the environment that we're in, if it's a positive environment where there is substances, then generally we will continue to seek out that reinforcement. If it's a negative environment where we see the alcohol and drugs and substances, that may cause us to decrease substances. Cultural and ethnic influences is very interesting. The culture, we talked a little bit about that with social learning, but how culture can and tradition of drinking, how we are brought up in our family, the culture of our family and our community very much has an influence and how we view substances and how we use substances. Your book, go ahead and read that, has a lot of good examples there. There's also ethnic influences in metabolism, such as with American Indians and Eskimo Indians. And so there are also those ethnic influences. Now we'll get into a little bit with the substances. First of all, alcohol. We know alcohol is a CNS depressant. It is a sedative, broken down in the liver. 40 or 95% of that is broken down in the liver. Your book talks about 4 patterns of use and 4 phases. So I want you to be familiar with that. The first phase is a pre-alcoholic phase. This is where a person is using alcohol as a relief for stress, for everyday stress, and it actually is a very acceptable way to deal with stress, or they have found it to be an acceptable way to deal with stress, say in that person's culture or in family setting, environment, community, and at this time many times a tolerance does start to develop. In phase 2, which is the early alcoholic stage, this is where we definitely start to see blackouts, which are brief periods of amnesia, loss of short-term memory, and make sure that you know the difference between what a blackout is and the difference between passing out. Okay, passing out is when you actually, basically, if you will, fall asleep. Blackouts is where you are still functioning and normally it's just that you have this amnesia, okay, but you're not passed out, you're still up and walking. So this would be the situation where you are out with your friends the night before and you the next morning they ask you, oh, so that was you that was standing up on the tables dancing and singing and all that kind of thing, and you don't remember anything of that. You had no idea that you were standing up on tables and laughing and dancing and that sort of thing. Okay, that would be the blackout. Also in this early alcoholic stage, alcohol becomes more required, and it's more than just like a sense of relief for stress, but that it starts to become a preoccupation. Many times you will, if there's an occasion that you're going to, a celebration, if there's no alcohol there, then you may choose not to attend it because you want to be somewhere that has alcohol. And oftentimes there's guilt and defensiveness also associated with this phase, especially when people start to bring up your drinking, or maybe that you are having some blackouts or unacceptable behavior. Guilt and defensiveness may start to set in. And this is also where the person would start using denial as and rationalization as defense mechanisms to cope with this guilt that they're having. So it's very important in this to assess, where people are in these different stages, and especially this early alcoholic stage. We want to be asking in our assessments is if the patient or if the client has experienced blackouts, or if people have told them that they have experienced blackouts. The third phase is crucial phase, where loss of control becomes part of the behavior. They lose control of the use of the alcohol. All right, so they have one drink and it turns into 10 drinks, but after one drink they cannot control that. They cannot stop their drinking once they have started. A physiological addiction is evident here. Many times people will go on binges. Drinking becomes their only focus, and they begin to have significant losses in their occupations, and it might be jobs, or it might be demotions, or loss of functioning in their job. Significant others, family starts to be significantly affected, and there may be many losses related to that. And then the chronic phase, phase 4, where there is physical and emotional disintegration. Person becomes very helpless, They have difficulty with reality, looking at themselves in a rational way, looking at their drinking in a reality-based way. And then we start to see many of physical manifestations setting in from chronic use, and many times we start to see life-threatening physical symptoms. Many different systems of the body, whether it be, liver, brain. But we also, it starts to become that if a person does start to withdraw in this chronic phase from alcohol, if it's not medically managed in the proper way, that withdrawal can become very, very dangerous, and a person could die from withdrawal. We also see depression and suicidal ideation many times in this phase as well. Okay, effects on the body. Many effects that your book lists, but I'm going to have you be responsible for these 4 that are listed here. The first one is Korsakoff syndrome. Some people call it Korsakoff psychosis. And basically, this is an alcohol-induced persisting amnesic disorder, if you will. In this disorder, the person has confusion, loss of memory, specifically recent memory. Many times we see confabulation with this. And this syndrome occurs with people who are drinking heavily for many years, and they also have a thiamine deficiency. And after this, long chronic drinking, many times, or what is occurring is that there is damage to the brain tissue, which is killing off brain tissue, and that therefore the confusion, loss of recent memory, confabulation, etc. If this person gets treatment early, many times Korsakoffs can be avoided. But once it is established, it becomes chronic and irreversible. And one of the ways that we can catch it early and treat it early is if we give large doses of IM thiamine. But many times we are unsure of, does this person have it? Are we seeing Wernicke syndrome? So many times when people come into the hospital for any type of alcohol withdrawal, we automatically give them IM thiamine. Usually the standing order is times 3 days, and also put them on a multivitamin to try to correct a thiamine deficiency if there is one that's going on. Okay, Wernicke syndrome is basically alcohol encephalopathy, which is basically a neurological disease. Again, this is also associated with chronic alcoholism. People with Wernicke syndrome have ataxia, nystagmus, and confusion. And you all should know what the term ataxia means and nystagmus. Okay, need to go ahead and look those 2 terms up. Wernicke syndrome also does respond to large doses of IM thiamine if we catch it in early stages and treat it in those early stages. Hepatitis is another chronic or effect from chronic alcoholism. It's inflammation of the liver after long-term use of alcohol, cirrhosis of the liver, where liver cells become destroyed and begin to be replaced by scar tissue. Cirrhosis of the liver, and you guys will learn about hepatitis and cirrhosis of the liver when you get into more of your med-surg disorders. Suicide and alcoholism, very important that we talk about this, that alcoholism and intoxication increase the risk of suicide. Alcoholism, or when a person is intoxicated, they become disinhibited in many areas of their life, especially for suicide. So many times when a person who would never consider suicide or would never act out on suicide, if they do become intoxicated, many times they will be so disinhibited that they may carry out a suicide or a suicide attempt. especially if there has been, if this is paired with a loss, say work, family, legal issues, which we know often occur with substance abuse um, and substance addiction. Many times that I've worked with individuals who have come in for a suicide attempt when they were drinking, they're on the mental health unit, they, talking with them in the morning, and now they are sober and they just voice or, express, regret. Oh my gosh, I would never have done this if I wasn't drunk last night. I can't believe, that I actually tried to overdose on these pills or actually tried to, do whatever the attempt was. But so it's not uncommon for that to happen. Okay, the next thing that's in your outline is a table of blood alcohol levels and behaviors. And it's important for you all to know what the blood alcohol levels are and then the behaviors that are associated with this. You can see initially we have that euphoria that happens, mood lability, cognitive disturbances that decrease concentration, impairment, disinhibition, and this is where we start to see, legal levels for intoxication, especially because it's starting to impair a person's judgment and especially with driving. And as you can see, as you move down that table where the behaviors start to change in this second group there, slurred speech, staggered gait, and then at point 3, aggressive behavior. This is where we can start to have incoherent speech, difficulty with breathing, vomiting, stupor. Person can eventually then go into a coma, severe respiratory depression, and death. Now, somebody might say that, I've worked with people in the emergency room and they come in and they might have a blood alcohol level of 0.32 or, getting up to 0.4, and they're sitting on the edge of the bed and they're talking with me and they aren't showing any of this, vomiting in or stupor or, even in a coma. And so the question is, why can one person be at a point, maybe, 0.35 or 0.37, 0.39, and seem like, they're not intoxicated or they're not, at this level of behaviors? And that is because they have developed a tolerance. Okay, so after chronic use, tolerance definitely develops, and so some of these we might see different behaviors, but that will be a clue at what stage possibly their alcoholism is at. But if we have a person who is not an alcoholic, has not been chronically using alcohol, and they do get up to a 0.3, 0.4, 0.5, that's where we can have very serious alcohol overdose, and people can die. And oftentimes, at least usually when I hear about people going into comas or death, unfortunately, is many of the hazing situations in fraternities that we hear on campuses. I know when I was up in Wisconsin, there was a really sad story of a haze. I think it was fraternity rush time in the fall, but one of the hazing things that they were putting these recruits through was, just this lots and lots of drinking, shots and that sort of thing. And many of these people were freshmen, probably hadn't drinking that much, or maybe they had, but there was one boy who he passed out, and they thought, okay, well, we're still partying and stuff. We'll just put him in the back of the car. I put him in the back of the car, and then, whenever they came out in the morning to check on him, or, early morning, he actually was dead. So that was a very, very sad story, but that definitely can happen. Okay, alcohol withdrawal syndrome. I want you to take out page 300 in there. Sorry, that's the incorrect page. But alcohol withdrawal syndrome, after a person is addicted, after a tolerance is developed, when the individual stops drinking, signs and symptoms start to develop as the blood alcohol level drops. We can begin to see minor withdrawal after 4 to 12 hours after the last drink. And these will be minor symptoms such as anxiety, agitation, some irritability. That's what we first start to see. That could progress into maybe some tremors, tachycardia, hypertension, okay, as it starts to progress. After we start getting further into that, closer maybe to the 12 hours, or maybe, even going into 20, closer to 24 hours, we can start to see diaphoresis, GI symptoms like nausea, vomiting, diarrhea, anorexia. Signs and symptoms of this minor withdrawal usually peak at about 24 to 48 hours after the last drink. Now, we can have major withdrawal, which is very serious, and this usually develops 2 to 3 days, 48, 72 hours after the last drink. Okay, and this can be potentially life-threatening, because if you're going through major withdrawals, there's always the potential for you to go into delirium tremens, or DTs, which can include hallucinations and seizures. And anytime a person begins to have seizures, we know that that can be life-threatening. So these DTs, or these hallucination seizures, that is really the hallmark symptoms of major withdrawal. Also in major withdrawal, we can see increased body temp, and all of those symptoms that we just talked about in the minor, such as the tremor, tachycardia, hypertension, all the GI problems, can also be in this major withdrawal. But as it continues into that major withdrawal, all of those symptoms are going to become much worse. Okay, so one of the big questions we always want to ask on admission, or when we're doing assessment, is when was your last drink? Okay, and if the person is coming in and they said maybe it's 9 o'clock in the morning, and they said their last drink was at 8 o'clock in the morning, we can kind of gear our interventions and prepare for the minor withdrawal, but we can also anticipate that, depending on how heavy and chronic their alcohol use is that we might not be seeing this major withdrawal until 2 or 3 days later. But if their last drink was 3 days ago, we can start to anticipate that this person might be just around the corner from going into a major withdrawal, and our interventions and the way we plan our care is going to be a little bit different. So it is very important that we ask, when was your last drink? Okay, treatment for withdrawal. I'm going to talk a little bit about treatment right now, but then we're going to also talk about it in the nursing process. First of all, we want to monitor the patient's fluid status, especially for dehydration. And we want to encourage fluid as much as possible. The person may need an IV, especially if they can't keep any PO down, or they, for whatever reason, if they're too sedated or confused to actually take sips of water or to drink. Many times, not all the time, we may see magnesium sulfate ordered, and this is to decrease the irritability of the central nervous system and to prevent seizures. Vitamin B1 or thiamine in a multivitamin is usually a standing order for somebody who's coming in for withdrawal. We know that alcohol interferes with the absorption of B vitamins, so we are always anticipating that the person is going to have a deficiency with thiamine, and a malnutrition. Many times people will drink their calories instead of eating and having a balanced diet. And if you remember back to long-term effects of alcoholism, we talked about Korsakoff syndrome, and we talked about Wernicke's syndrome. And if we treat both of those early with IM thiamine, many times we can, and if we catch it early, we can prevent those two syndromes from developing. Benzodiazepines, I just have abbreviated benzos, but those are the benzodiazepines. This is a treatment that many people will call substitution therapy, where we are basically substituting a benzodiazepine, which is a central nervous system depressant. We're substituting the benzodiazepine for the alcohol, and slowly letting the central nervous system come off a depressant, but we are now in management of that with the benzodiazepines, and we're really trying to prevent that person from going into DTs and eventual seizures by using the substitution therapy. So Librium is often used for substitution therapy. Ativan is often used. And in class, our next class, we are going to be actually going through a case study of alcohol withdrawal, and we'll be using the CWA scale and really looking more closely at alcohol withdrawal. Number 5 there, I just have that kind of open, but many times you may also see other anticonvulsants being prescribed for withdrawal seizures, okay? So maybe in addition to magnesium sulfate or without it, but many times there'll be anticonvulsants that are ordered. So again, just make sure that you can answer the question, why is early detection of alcohol withdrawal so important? Okay. So, can you answer that? And the main thing we want to be looking at here, it's very, very important, because we do not want a person to go into that major withdrawal without some kind of medication management and close supervision. If they do go into major withdrawal, again, potentially it can become life-threatening and the person can have seizures. So we want to treat that withdrawal and make it a safe environment for withdrawal. Long-term treatment after withdrawal and detox is done. 2 medications that may be prescribed: dalsurfaram or antabuse. That should say antabuse, A-N-T-A-B-U-S-E. On page 443 in your book talks about it, but this is basically a medication that deters drinking. Usually if a person is on this antabuse and they take a drink of alcohol, usually within about 5 to 10 minutes they will develop nausea and vomiting, a respiratory difficulty, headaches, diuresis, tachycardia, hypotension. And so it's a very, very severe reaction that they have when they mix this antabuse with alcohol. And so what that does, hopefully for the person, is it helps them control impulse drinking. If they know they're going to get incredibly sick from taking a drink of alcohol, hopefully that is going to be, negative conditioning, and they will not drink, or it will deter their drinking. Now, Traxone is another medication that can be used for long-term treatment, page 445 in your book. And basically this is decreasing the person's cravings and for alcohol, which can be beneficial to them. But also if they do drink, it also hopefully is going to decrease the euphoria that goes along with that. Okay, so that is the end of the alcohol. Now let's talk about stimulants. Stimulants actually stimulating the central nervous system. The effects that can be seen with this is a person who is on, any type of stimulant, which can range from the legal stimulants to, amphetamines, meth, etc. We'll just go through a little bit of that. Cocaine. A person can have decreased fatigue, euphoria, greater mental abilities, if you will, for a short time, or they just become a little bit sharper, increased heart rate, increased blood pressure, arrhythmias. If a person uses stimulants chronically, paranoia can develop and hallucinations. And again, you can see that legal stimulants are there. Many of us may use caffeine, maybe some of us use nicotine. Dexedrine is usually the thing that we see with diet pills, that sort, those medications. And then Ritalin is also a legal stimulant. Illegal stimulants like amphetamines, methamphetamine, speed, usually is used in a binge and crash pattern. We have all sorts of ways amphetamines are being developed, bath salts, and with various names. Hopefully, next class, I may hopefully show you a video of a person who is high on these methamphetamines. Really, there's a lot of different YouTubes on it, but very, very interesting. So you can see the effects there with amphetamines can be dangerous: agitation, paranoia, etc. Long-term effect, basically a neurotoxin is being introduced into the brain, and there can, with long-term effect, neurological damage. So we see cognitive decline. We can also start to see skin lesions and hypertension. Treatment with methamphetamines when a person is in withdrawal is usually with Valium. So just to kind of somewhat of a substitution, not really a substitution therapy, but to slowly, as they're coming off of that medication, just to keep them calm. Okay, let's start talking about opioid use, or opioids. We know that opium, heroin, morphine is from the poppy plant. These are the natural opioids that are synthetic would be all of those that I have listed down there: codeine, Percocet, Oxycontin. These are mostly used pain medications, often with chronic pain. But we can also see these oftentimes being prescribed after surgery, so shoulder surgery, ACL surgery. Many of you guys may have been on some of these medications for different surgeries that you've had. But if a patient is on these for a chronic period of time, they can go through withdrawal when they stop the medications. You can have some withdrawal signs and symptoms. And it's not unusual to hear, some sports celebrities or other celebrities who have been addicted to, some of these synthetic opioids after some of their surgeries, and have testimonies of how hard, it was difficult to get off the medication, and how they, maybe even continued on the medication after. They didn't need it any longer, but it was just too hard to, stop, and so they may have abused prescriptions, or sought out prescriptions, or even started to obtain it illegally. Effects of opioids give a sedative and analgesic effect. They desensitize the person both psychologically and physiologically to pain. You can see the symptoms I have down there for intoxication. Basically, the patient is becoming high, they're drowsy, out of touch, definitely have poor judgment with this intoxication, constricted pupils. When we start to have an overdose, that's when the person becomes unconscious, slower, shallower respirations, bradycardic, and when this starts to happen, when the respirations go down, this is where a person can be, puts them at serious risk for death. So we treat the overdose with Narcan, which is a narcotic antagonist. You also might know it as naloxone, Naloxone. And this basically is counteracting the respiratory depression. You guys may have heard the push in the past couple years to have Narcan available to first responders, and also to possibly to family members, or those that are most likely to be around someone who ODs on medication. So they are exploring other routes besides, IM or sub-Q injections. They're also looking at intranasal applications for naloxone. We're also seeing a lot more of people that are actually overdosing and death with a mixture of fentanyl and heroin, and that is very, very easy to overdose when both of those are combined. And that is usually the case, is that when we have people who have substance abuse, they're not, many times are not just using one medication to get their high, or to prevent themselves from going through withdrawal, but using combinations of medications. Withdrawal symptoms, we can have Early symptoms of withdrawal are muscle aches, restlessness, anxiety, teary eyes, runny nose, sweating, the inability to sleep. Later signs and symptoms are diarrhea, abdominal cramps, nausea and vomiting. Sometimes people will describe goosebumps, rapid heart rate, increased blood pressure. And I just always remember this, and an easy way to kind of remember these signs and symptoms is the person just feels like they have the flu, and it kind of looks like the flu, whether it be, with their diarrhea, muscle aches, all of that kind of stuff. And you can see how uncomfortable that would be and how somebody would want to stop those withdrawal symptoms. So that's why many times it is hard to, if you're going cold turkey or if you don't have your medication, many times people will then start to seek out the medication just to prevent themselves from feeling all of these symptoms that are listed down here under the withdrawal. Usually we start to see withdrawal 36 to 48 hours after the last use, and it can last up to 2 weeks, so that is a pretty long withdrawal. And usually what is accompanying that withdrawal is craving of the drug. Now, when we get into pediatrics and newborn babies born to mothers with the opiate addiction, many times will have digestive issues, have difficulty feeding, many times they have dehydration, and they also are having vomiting and seizures, and basically those babies are born with an addiction as well and have to be treated and basically go through withdrawal as well. Okay, treatment is for opioid addiction, buprenorphine, which is Suboxone. That should be S-U-B-O-X and not a Z, O-N-E, or Subutex. This is an opioid. This is an opiate. It's not as addictive, so it's less likely to be abused. And this can treat signs and symptoms of withdrawal, shorten the intensity of the withdrawal period. And shorten the length of detox. Methadone also may be used. Methadone can help with withdrawal, although methadone is another type of synthetic opiate. It can help withdrawal, and then we would gradually decrease them off of that methadone. But it's a synthetic narcotic, like I said. Many times people are on long-term maintenance programs of methadone. Maybe you have heard of methadone clinics, and they may never get off of methadone. But the belief is that if we can have this in a prescribed manner where it's managed by a healthcare provider in a clinic, then that is going to prevent overdoses. It may also prevent people using, dirty needles, and it may help to get this person back in a job, accepting responsibility of their lives. So the methadone, if it's used in a controlled manner, does not have the rush or the high that other types of opioids would, and can block some of the effects of the opioids. It also will help with decreasing cravings. Cannabis use disorder. Cannabis contains THC. You guys are familiar with that, found in the hemp plant. THC is stored in the fatty tissue of the body, and it can be detected in the body. Some people will say up to 6 weeks. Again, that depends on how long and how much THC is used. We do know that there's some analgesic effect that helps with, some of the nausea and vomiting symptoms of chemotherapy. There have now been, lots of studies that have shown some of the THC oils can help with some seizure disorders. So there are finding a lot of, valid medical, effects of cannabis. And so many forms of it can be used for medicinal purposes. One thing I wanted to go back to is that some people will say that THC can be detected up in the hair up to 3 years. So that's just kind of a FYI there. In moderate doses, and well, just let me, before I get into that, we also know that many states now are legalizing marijuana, and you know, some people find that controversial, some people don't. It's an interesting discussion to have, but it's good to reflect on, you know, what are your feelings about that? How much should it, now that it is legalized in some states, how much, you know, control should the government have of it? Again, lots of arguments about that. A lot of times the marijuana that we're seeing today, which is that's sold illegally, is not necessarily the marijuana that, you know, people will say it's not your parents' marijuana anymore. But many times the marijuana today that's sold illegally is laced with lots of other types of chemicals that make it much more harmful to people today, and especially to adolescents and young adults that are using it. So anyway, lots of discussion. We won't have that here now, but moderate doses of THC, you can have central nervous system depressant effect. It's difficult to find where marijuana or THC, what exact class it fits into, even though it does cause, you know, central nervous system depression. It can also produce hallucinations in high doses, and I have seen, you know, and I don't work with substance abuse all that much anymore with just in teaching, but still have seen cases where adolescents have come into the ER after a first or second use of marijuana with hallucinations. There's also studies that are being done that if a person has a predisposition to, like a genetic predisposition to schizophrenia, and they use marijuana, that can be another predisposing factor to cause that schizophrenia to become evident or to begin in that person's life. Psychological addiction can occur with marijuana. A person, and there has been shown that chemical dependency can develop after 10 to 15 years in adults, which is a pretty long time, but can develop. But with children or with adolescents, that it only takes a few years for that chemical dependency to develop. So we know a tolerance can occur with chronic use. The DSM-5 study group is looking at cannabis withdrawal, and they are showing so that we are seeing that you can have withdrawal from cannabis after heavy use. And the DSM-5 study group is also showing a strong correlation between marijuana use and alcohol and tobacco, cocaine, and meth use. So again, there's that controversial discussion, is marijuana a gateway drug? And many people say no, it's not. And you know, then there's the study group that is saying, well, whether it is or not, there is a strong correlation with marijuana use, alcohol, tobacco, cocaine, and meth. So interesting studies that are going on out there. Okay, let's see here. Let's go to effects. Cardio effects, tachycardia, hypotension, respiratory effects. We know that tar can be deposited in the lungs of people smoking marijuana, and so chronic use, we can have respiratory problems and respiratory issues. Reproductive effects, with heavy use, cannabis can decrease sperm count and motility, and can also suppress ovulation. So withdrawal, again, I kind of already mentioned, but that yes, we can have withdrawal with heavy use. Just let me go back up to effects for a little bit. In the central nervous system, as far as the effects goes, you know, it's very much dose related, but a person can, if you will, become drunk, or you know, because a euphoria is produced, they can become very relaxed. If you increase the dose, of cannabis, it can alter the person's senses, it can alter their judgment, it can also alter their judgment of time and distance. Long-term use of cannabis, studies are showing, and people have put together a motivational syndrome, that studies have shown that a person with long-term use can have a very decreased motivation. It can start to affect their cognitive functioning, can affect their memory, their attention, their organization. And when we talk about long-term use, we're not talking maybe 10 or 15 years, but remember we said with children, adolescents, and young adults that addiction can occur quicker, and long-term use may only be, for 1 to 2 years. So this amotivational syndrome can definitely set in. So the question then becomes, if you are a pediatric practitioner, pediatrics nurse, if you become a nurse practitioner in peds, or if you decide to go into psychiatric adolescents, what should health providers, practitioners be doing with their pediatric clients and their adolescent clients related to, this cannabis use? What should be our role in this? And, what is the government's role in, looking at driving high, not just drunk driving, but driving high on marijuana? What kind of program should we be, having for kids to be educating them about, the addictive properties of marijuana, the difficulties, that long-term use can have. Very, very interesting studies that are coming out that are showing how with adolescents who are using cannabis, that it can definitely start to affect the development of the brain. And I'm not going to go into all that now, but it is a big concern for us as healthcare providers. Okay, the next group is, I talked a little bit about CNS stimulants already. I'm not going to, this next area that I have on your outline, which is the club drugs, hallucinogens, can't pronounce that. I am not going to go into that. I just have those listed there, but you won't be tested on any of that. Your book doesn't really talk about this, but groups at risk, I want you to know that, and this is somewhat common sense, but people that are more at risk for addictions would be teenagers, psychiatric patients, oftentimes are using substances to self-medicate. Many of their symptoms of either depression or of hallucinations or paranoia. Women are at a higher risk group. Generalized hospital patients, older adults, believe it or not, are also more at risk, especially with alcoholism. Adult children of alcoholics are at greater risk. And healthcare providers. You'll talk more about healthcare providers and the addicted nurse more when you get into your 3rd and 4th semester. But why would healthcare providers be more at risk? And you guys can probably answer that, but healthcare providers, especially nurses, oftentimes have, nursing is a stressful career. If the person does not have a balanced life, if the person does not have healthy coping mechanisms, and also nurses have easy access to many of the medications, that we have talked about, or to addicting medications. Now, this next part of this outline, I'm providing you with another PowerPoint, just so that I'll break it up a little bit. So I'm going to be ending the PowerPoint here, and the nursing process will be on a different PowerPoint. So I'll be ending now. Please let me know if you have any questions related to any of this, and I will see you in class on Tuesday.